Hello again. Today we're going to discuss a very important topic, that is graft rejection. Graft is synonymous with transplant, right? So graft or transplant is when you take a tissue or an organ from one person and you insert or implant it to another person. Before we get into transplant rejection, let's go through all the types of transplant. And that is very important to understand. Now, a graft can be classified into four types according to the donor. If the donor is yourself, it's called an autograft. Like you take a skin graft from you and put it in yourself. Another site, like a burn scar or granulating wound. A graft is an isograft when it is taken from your twin, your genetically identical twin. A graft is an allograft when it is taken from a different member of the same species. And the graft is a xenograft when it is taken from a member of a different species. Now, an auto and isografts are never rejected. A xenograft is always rejected because it's all genetically very different. Always rejected. An allograft is usually rejected. Okay. So in this video, we're going to actually be talking about the allograft rejection. Now, allograft we know about is mostly done the renal graft or the kidney graft, the liver transplant, and cardiac transplants. But here we're going to discuss about renal allograft rejection because it is the prototypical type of graft when we discuss about graft rejections. So when we talk about graft rejections, we actually are talking about the pathophysiology and how a renal allograft rejection works. And the same pathophysiology can be applied to other types of rejection, though it can be slightly different, right? But when the questions come up, it is usually from the renal allograft rejections. Okay, so let's get into it. Okay, so to better understand graft rejections, we're going to compare it side by side. So it will give you a better idea of how each other compare to the other, because we get sometimes confused and the questions are usually not confusing, but still it is very important to have a clear and concise idea. So graft rejections are of three types: are hyperacute, acute, and chronic. Graft rejections are divided into these three types on the basis of the timing of the rejection that takes place. Hyperacute rejection usually takes place at the time of surgery or within the first 24 hours, right? So the questions will come up that a person is going through a transplant, and during the surgery, the surgeon notices some changes. So you immediately think of hyperacute transplant. Usually you don't need to read the rest of the question. These are the clues, the killer points that you have to identify. Sometimes the question is very big and there will be many points that are quite confusing. They will give you some weird physiological or pathological terms to throw you offset, but there are some killer points that you have to look for, that when you see them in a question, you will not have any doubt so as to it is this or the other, right? So if the question says during the time of surgery a surgeon notices and whatnot, and you see many other languages that you think are trying to throw you off, you don't look at them and you think of the hyperacute rejection. So it takes place within the first 24 hours. The acute rejection takes place after the first 24 hours, 1 day, to 6 months. So it takes place within the first 6 months, and chronic rejection takes place after the first 6 months. Now, the cause of hyperacute rejection. Cause of hyperacute rejection is usually preformed antibodies. These are usually against the human leukocyte antigen antibodies, HLA-1 antigen antibodies. Now, because of HLA typing, that is very rare, but it still can happen. If a person has taken many blood transfusions before, has had repeated pregnancies, or has had previous episodes of graft rejection, hyperacute rejection can still take place even if a person is HLA typed and matched. So HLA immunoglobulin G antibodies in the blood can cause hyperacute rejection. It can, when the graft is inserted, the antibodies cause activation of complements that cause immediate destruction and thrombosis of the vessels. An acute rejection is due to mismatched HLA. Now, important thing or segue to get into here, the HLA or the human leukocyte antigen is also called MHC, the major histocompatibility complex. Now, these are of two types. When we talk about HLA typing, it's of two types, HLA type 1 and HLA type 2. Type 1 are three types of genes, A, B, and C. And type 2 is DP, DQ, and DR. In HLA typing, the A, B, C, and DR are matched, but DP and DQ are not matched. If a person has 8 matching HLAs, that is A, B, C, and DR, it is said that the person will not have a graft rejection, but that is not always true because an acute rejection can also take place. It is usually due to infiltration of the T cells and the mononuclear cells. And a chronic rejection is due to the slow vascular intimal proliferation that takes place over more than 6 months, and it will take place, is due to vascular changes. Okay. So what are the clinical features? What in the questions, what are the features that you're going to see in case of hyperacute rejections? The question may say that during surgery, the surgeon has removed the vascular clamps and suddenly the kidney has become dusky and swollen, right? And that is without a shadow of a doubt, hyperacute rejection. So you don't really think about that. If a question says a 50-year-old person is going through renal transplant, the surgeon has completed the operation, has removed the vascular clamps, and suddenly the kidney becomes dusky, swollen, or white. Okay, so then it is hyperacute rejection. The treatment of hyperacute rejection is surgery, because the kidney cannot be transplanted. You have to do another surgery or take another kidney for transplant. So in acute rejection, what will happen is the question may say that some 50 or 40-year person went to a renal transplant, and after a month or 2 months, he will come with decreased urine output, swelling of the body, of edema, and a generalized feeling of unwell. That means the kidney is not actually working. So it is a type of acute rejection because it is taking place after the first 24 hours, but within the first 6 months. So, okay, the treatment of acute rejection is medical by using steroids, and if that fails, monoclonal antibodies. And chronic rejection will present with features of renal failure, after the first 6 months of surgery. And the goal of immunosuppression is actually to prevent or to delay chronic rejection. So chronic rejection can be prevented by giving immunosuppressants, such as steroids and other drugs such as azathioprine, cyclosporin, tacrolimus, and monoclonal antibodies. So that's it for today. Hope it was helpful.